Welcome to the Breathe, Sleep, and Be Well podcast, where we uncover a hidden epidemic right under our noses. An epidemic that most often begins right after birth.
We aim to engage in casual conversation in a way that raises awareness, exposes misinformation, and challenges us to understand that just because something is common does not mean that it is normal. There is a difference between not being sick and being well.
In our goal of maintaining a casual conversation format, we hope that you, our listeners, will engage in the conversation through our platform.
Our cardinal goal is to provide easily accessible yet accurate information to the public at large and facilitate a discussion between the healthcare provider and the patient in a way that targets root cause of common diseases and dysfunction rather than merely managing the symptoms.
I'm your co-host, Brendan Cruz, and I hope to bring an understanding of social media and communication to highlight my father's journey over the past 15 years. And this is my co-host, Dr. Mark A. Cruz, who has been connecting the dots and teaching on this complicated subject since 2006. To learn more about Dr. Cruz, view his curriculum vitae at markacruz.com/biographical-profile. Without further ado, here's the conversation.
Just subconsciously, this is happening?
Right,
Really?
exactly, because they abort the breath. We can measure this with capnometry. I do that all the time. It's a validated medical device that allows for measurement. The anesthesiologists will use it as a more precise metric of the respiratory status of a patient that's under general anesthesia versus, say, oximetry. It's moment to moment. So what happens is people will, let's say in a busy day, you can, you're over breathing, you abort the breath, you're breathing shallower, your chest breathing, it's a lot more effortful, and that stimulates a low-grade fight or flight. So it's the way you know it. You might be amped, you might be focused, you're not so much like that, but you're breathing more. But what happens is you're blowing off too much of the acid, the CO2. So what that means is that when you're getting rid of more of the acid, your blood pH is becoming more alkaline. It's going up higher and higher and higher. And so now the body has to respond to keep it within that narrow range. And that stimulates what's called a metabolic compensation. And one strategy is the kidneys start dumping bicarbonate, which is a base. So you get rid of the base, which elevates the blood. So again, I don't want to get too much into the pH, but there's a lot that's going on behind the scenes physiologically. And although you could take breath work or yoga and doing all these things, I can argue that you should be able to breathe optimally regardless of what task that you're involved in. So in our busy days in the West, we're constantly at go, 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 go. We wake up in the morning, we have caffeine, we're eating carbohydrates, that's, raising our breath work. We're alert, but we're actually not in the sweet spot physiologically that we should be. And then at the end of the day, we have to walk ourselves off the ledge, if you will. That's what we call happy hour, right? It's in our culture. Okay, I'm done. I'm off the hamster, wheel, and then I have to try to be calm. So that all has to do with breathing. You might go to the gym, and the gym helps to reset our breathing function, if you will, where we feel great at the end, and we're thinking, well, it's the endorphins. Actually, it's not. You're actually closer to a more physiologic state that you should always be in.
So we're not breathing optimally because we're breathing too quickly, because we're stressed.
Right.
Okay, and what they do in the East or Eastern medicine or yoga is that we're adopting now. The point of it is the slower breathing down. Is that how it helps?
Okay, so that's one strategy. There are many, many strategies to attain what I just described, and I could say it goes back over 2,000 years, right? That the physiology wasn't really understood as we understand now. But let me just maybe use a sports analogy,
okay.
Right? We certainly understand in sports if there are 10 seconds left to win the game and you have the point guard that's at the free throw line to make the 2 points to win by 1 point or to send it into overtime, what do we say when he clinks the shots? They don't go in. He choked. Or the NFL receiver that, the ball was hit him in his hands in the corner of the end zone to win the game and he drops it. So think about it. It's a very stressful situation for the athlete at that point in time. He's in battle or she's in battle. And at a time where you function best when you're chill and calm. That's why the Michael Jordans and the Kobe Bryants of the world, you give them the ball because they're calmer than everyone else. The hoop is bigger. They can make the free throw. Well, what's going on there? It's how you breathe. If you start breathing with a fight or flight response, our athletic moves aren't quite as fluid or as precise. So we miss the free throw or the catch. Does that make sense?
Well,
we say that they choked.
Right.
Is they're not breathing. We don't even understand what we're saying.
I guess I can make the connection. What was getting me for a second there is athletes in a stressful situation, they have a lot of adrenaline, right?
Yes.
But I guess adrenaline isn't directly correlated to being stressed, or is
well,
it?
yes, it is. Adrenaline, by definition, is part of the stress response, and a good athlete is able to garner and control that stress response. Whereas, let's say the average Joe Blow, for example, let's say you're in a house that's in fire. You wake up in the middle of the night, it's burning, and you have those individuals that start panicking. They run, it's dark, and they run into the walls, and they're hyperventilating, and they can't save themselves, right?
They just deal with the adrenaline.
It's a fight or flight adrenaline to just get them out of danger, but that actually requires some cognitive function, whereas the firefighter, who's a professional, comes in with their mask, slowly breathing, they're calm.
But they have adrenaline coursing through them too, right?
Well, all heck is coursing through their veins, but they're able to stay calm and think clearly and and save the lives.
I guess it makes sense. Adrenaline's a dilator, right? Isn't that why they give?
Has many effects.
EpiPen.
It has many effects having to do with respiration and the distribution of gas, no question, and that's a real big discussion. But what I want to focus on right now is in that breathing function that allows us to slow the heart down. So there are many studies in exercise physiology looking at sports performance as it pertains to slowing the heart down and being more in that parasympathetic versus the fight or flight. And you slow the heart down so you're holding the gun to hit the mark. You're able to calm everything down. How do you do that? By breathing. In fact, there's a recent FDA-approved device that you've probably been hearing all over the news called Respirate, to help patients that have hypertension to just be able to have this biofeedback to slow their breathing down.
Hypertension meaning?
High blood pressure. High blood pressure. And it's been FDA approved to show you can actually slow or lower your heart rate without medication by how we breathe. So that's why people who do yoga and breath work and meditate.
So your blood pressure gets higher?
They're healthier, yes.
Your blood pressure gets higher when you overbreathe?
Well, it's not that easy of a question to answer, but essentially you have spikes from the stress hormones, if you will. Again, we're kind of getting into the weeds a little bit, but why do athletes that are out there on the field or on the court use breathe rights? Right? It's just to get that little bit of edge for to dilate the nasal valves to get better distribution of the oxygen through the release of nitric oxide through breathing more optimally the way we were designed to breathe. And what's happened in the West in our 21st century is we just don't realize how the traffic, the stress, our boss, our to-do list is altering our breathing. We're in this go to battle and we're in this constant state of overventilating that causes anxiety, depression, irritable bowel syndrome, high blood pressure, and then we go to fall asleep. And it continues when our airway is even more vulnerable. So there are all these things that are causing, bottom line, inflammation in the body. And inflammation is the body's way of telling us something is not right. And the body's constantly trying to address that behind the scenes. And what we've learned in an allopathic healthcare system is to treat the symptom with a medication. It could be a proton pump inhibitor for acid reflux. It could be a medication to calm us down, to slow the heart rate down, et cetera, et cetera.
So, I understand that what I gathered from that, right, is that we have to slow our breathing down. One way or another, we overbreathe due to stress, okay? But should everyone just be meditating? Like, should I meditate or should I?
Well, no, yeah. So this is.
Should I do breath work?
So this is, yeah. So this is the interesting thing. I'm not going to even say necessarily to slow your breathing down. It's about what's called, I'm going to use a term, it's called end tidal CO2. And what that describes is the amount of reserve carbon dioxide that we should have in our lungs. And that's been very well defined as a biologic imperative, meaning we're supposed to have this. It's 35, you can measure it, 35 millimeters of mercury, which measures the pressure, if you will, that's in our lungs. Optimally, it should be closer to 40, maybe up to 45 millimeters during the day. And what that portends to is breathing stability. So let me give you an example. Someone who's in chronic pain, when they're in chronic pain, they're breathing more like what's called agonal breathing. You know, it's just disordered breathing. They're shallower breaths more often. But that breathing behavior that they can control actually blows off too much carbon dioxide. So the studies show that if you are doing that for more than 6 to 8 hours, again, let's look at a chronic pain patient. For more than 6 to 8 hours, the body always wants homeostasis. It's going to lock you into that breathing pattern by compensating metabolically through the kidneys. That it's all to maintain a blood pH within this very, very narrow range so that you don't get sick or symptomatic. Those patients are struggling constantly, and they will use the adrenaline response, if you will, to maintain that, to run the engine hot. They're able to breathe, they're able to live, they're in chronic pain, but they're not well, okay? They're not optimal. So that's one example, but most of us in the West, with our busy lifestyles, are waking up already behind the 8 ball, and we're overventilating. All the things that we do environmentally, we can get into a whole list. And so if you want to be calm, let's say you're going to be taking a test, you don't want to be in an adrenaline response because you have vasodilation when you are in parasympathetic coherence, when you're on the other side of the autonomic system, what we call rest and digest. So when you're very clear thinking because you slowed your breathing down and a lot of blood going to the brain, it allows us to think more clearly, to recall more clearly, to solve problems more clearly. And we do that moment to moment in our days. So if you can get to that point and overcome that metabolic compensation with a physiologic approach, if you will, to keep that as your set point, always, regardless of what you're doing, then you will have arrived. The problem is people will go to the gym, or they'll take breath work, or they'll do yoga on occasion to do something that the body should already do competently always.
And automatically, right?
Automatically. This is what we call a compensation. And we don't recognize it for what it is because it's so common. It's just the way it is. So we're finding out now from studies that it's very pro-inflammatory. Again, I talked about it the last time. We have upregulated TNF alpha, IL-6, highly sensitive C-reactive protein. These are names, fancy names for these molecules that are putting our body in high alert that cause us to always be compensating and create a lot of signs and symptoms where we're chronically sick. And so breathing is a very, very important moment to moment, and we just haven't learned to do that very well, other than by talking about different modalities that will help us from time to time when we perceive that we need it. I'm going to argue.
When you're conscious of it, but when you're subconscious of it,
it should be happening subconsciously.
So when I'm taking a test and I'm just subconsciously over breathing, what's the practical take-home advice I could do to perform?
First, understand it's a behavior that you control it.
Okay.
And so you can, calm yourself, slow down. You also become less emotional too. That's the other thing. When you're emotional, you don't think as well because that's a more primitive.
How do I slow down? How do I calm down?
You just slow your breathing down, breathe through your nose, take a deep breath. You're sending a message back to your brainstem. You're metabolizing and retaining more carbon dioxide. Because the carbon dioxide, not oxygen, it's the carbon dioxide that tells our brain to take the next breath.
In through the nose,
it's not
out
oxygen.
through the mouth.
Yes.
In through the nose, out through the
in
mouth.
Through the nose, in through the nose, out through the nose. Unless you're a big athletic, where you're moving more tidal volume, then that's a different story. Then you can exhale through the mouth. But optimally, and that takes training. It takes time to really learn that is a very basic function moment to moment. And therein lies the problem is we just kind of accepted it as, well, we're breathing, we're alive. The anxiety has to do with my boss or the traffic, not really realizing, because we conflate physiologic stress with psychological stress. And I'll argue that most of the stress that we have, or a lot of the stress that we have, has a physiologic basis for it first and foremost. But psychological stress has a part of the brain that can access the language center or the language part of our brain that we can express it. Physiologic stress does not. So it doesn't get really represented. So we think, oh, I'm really anxious right now. It must be the last thing that I do. It must be my to-do. I just call that life. Our ability to deal with life, if you are breathing optimally, becomes much easier. It's not going to change the fact that there's a tragedy or that there's a stressor or that, but your ability to deal with it you become more competent at it if you're functioning optimally with your breathing behavior. And so some of the things that we talk about are the structure and the function. The structure, the size of our airway, how our faces grow, which we'll get into facial beauty and facial attractiveness, which is our next topic. But it has a physiologic basis. That's the point. It has a physiologic basis, form follows function, that sometimes is not recognized.
So 90% of the time when I'm driving, when I'm taking a test, I should be breathing in through my nose, out through my nose.
90 to 95% of the time.
90 to 95%
Yeah, and there's data more recent data that actually has shown that.
And if I'm jogging, in through the nose, out through the mouth?
Yeah, that's fine. But just notice if you start doing that, let's say you get on the treadmill or on your Peloton, start off breathing through your nose consciously as you're metabolizing, as you're working. And then you might find that, it takes you 5 minutes before you start breathing more through the mouth. And then a week later, because you're consciously making this effort, it takes maybe 10 minutes.
Okay.
And then a month from now, it takes you a half hour before you get to the point where you're now sucking wind through your, what you're doing is you're functioning better, more efficiently the way you were designed. We used to, back in the day in the Paleolithic period, we used to run down deer for survival. We would just keep on running. We were just very competent in it. We were breathing through our noses, and we've kind of lost that a little bit, and so we're seeing it in how our faces are developed. There are lots of anthropology studies looking at that, but that's another topic.
So if I'm running or if I'm doing cardio, I should be breathing through my nose as long as I can.
Yes.
Until
Yes.
I can't. Until
Right.
I have to breathe in through my nose, out through my mouth.
Right. And
Okay.
so let me just say there's a fly in the ointment, as the saying says, that if you have, let's say, a very narrow arch, palate, you're also going to have the roof of your mouth. You have a very narrow base of the nose. Or if you have a deviated septum, where you can't breathe through one side very well. Or you have swollen turbinates. These are these bony structures that you see here that have become enlarged, that limit the amount of air coming in, and then you're going to do more mouth breathing, right? So again, that's where we have to address the structural risk factors that are involved.
So when you say the airway physically, where is it? It's the whole.
So the primary is coming in through this bony structure, which has a fleshy surrounding, cartilage and tissue, right, soft tissue, and that goes in through the nose,
right.
Okay, and then it comes out through the outside part of it. Okay, this is the nasal pharynx, the bony borders of the nasal pharynx, important part of the airway. Well, what's happened in the last 500 years is this has become narrower. It's much more narrow than it was, in the Paleolithic period,
So
certainly early medieval.
You
Yes.
used to be breathing out of a milkshake straw, and now we're
much larger. And the way we see it in our modern society is teeth that are crowded, because the arches, the teeth
I was
that
gonna
are.
say you did braces on him, huh?
You do braces I argue to over-treat the wrong problem. Dental crowding is not really a tooth problem. It's a bone problem. There isn't enough expression of facial growth. And why is that important? Because that facial growth largely is driven by the growth of the airway. And so there's where we start having these compensations with our breathing, and ends up affecting our sleep, et cetera, et cetera. So there's
So you're telling me you didn't do braces on him?
well, this skull is about 100 years old. It's typical of what we would see.
And the teeth are pretty straight.
And the teeth are very straight. There were no braces, back in India 100 years ago. As we define it now, that just happened naturally. And you can go back thousands of years to digs all over the planet, as we talked about last time. Dental crowding was rare. In fact, so was dental decay. But dental crowding was rare. The teeth were straight. You don't take any mammal, killer whales or monkeys, or you don't put them in braces. But if you look at their skulls and you look at their arches, their teeth are straight. Right. It's because they are growing as nature has intended. But we've radically changed our environment, yes, to the better for the most part in modern human society, but there are some problems with that. And we tend to treat a symptom like dental crowding as if that's the problem. In fact, sometimes we'll even pull teeth out to accommodate the teeth, and that makes the problem worse. Yes, we straighten the teeth out, but we make the airway smaller because there's less tongue space.
Are you telling me that straight aesthetic teeth are an indicator for your health, your airway health?
Not by itself.
Okay.
That's somewhat contrived. It's not so much that the teeth are straight, it's that, the arches are wide. In fact, it's more attractive. If you look at an individual that has you can have someone that has very straight teeth, but a very narrow arch. That's not
naturally though.
No. They went. Let's say they had
braces.
They had braces, right? So their teeth are like perfectly straight, but they're narrow. Okay, versus somebody who never had braces, but they have a very wide arch, and maybe the teeth aren't perfectly straight. But if you look at that same person in both those expressions, hands down, the person that has the broader smile, if you will, is going to be more attractive looking.
Okay.
And then also healthier.
Could you ever see someone with straight teeth but a narrow palate just naturally, like if they didn't have any treatment?
Well, yeah, it happens naturally all the time in this environment. But that's
Naturally
not...
without treatment. Does it happen?
Well, of course it does. But it's the exception rather than the rule. I think the better question, if I may, to ask is, what is it supposed to look like? What are we supposed to look like in the environment from which we evolved, which is the Paleolithic environment?
The broad...
Yes.
So how do you have a broad palate? Is it genetic?
Well, it starts from when you're born. Actually, we can argue it starts at the beginning of the third trimester, but we're not going to talk about that. Well, let's say once you're born, the infant immediately, naturally, like every other mammal, is supposed to latch onto mom, to nurse. Okay, so that's just one example of what we've radically changed, because we can, in our species, where bottle feeding comes around. And yes, we're feeding the infant immediately, oftentimes unwittingly not understanding the functional and structural risk factors that we're baking into that growth and development of that child that may manifest in any of a number of ADD, ADHD, allergies, all kinds of problems. So it starts with the latch, proper latch that requires more muscle function to grow the face forward. It's the muscles that grow our face forward.
So they're not experiencing enough muscle function when they're bottle feeding. Okay.
Right. So that's one example.
Okay.
And then now they're swallowing very different. So just think about it. When a baby latches on, they're eating and breathing at the same time. So they're not mouth breathing. They're breathing through the nose while they're also suckling, right? And so that function is what allows...
Wait, is that possible to swallow and breathe at the same time?
100%.
Not for us.
No, there's a momentary pause at the moment of what's called deglutition, that swallow.
Oh, so they swallow then breathe.
There's a cadence, yes. And by the way, that cadence is different for different people. It could be like three sucks, 2 breaths, 1 suck, 2 breaths.
Why is that?
It's what's called a central pattern generator. It's something that's part of the neurology from transitioning from fetal respiration to breathing atmospheric air.
Okay.
And it doesn't matter, but that we hold on to for the rest of our life. But that's called the primitive reflex that gets replaced with what's called a mature swallow. And so now we're starting to go down.
What do you mean that stays with us the rest of our life? Are you saying the pattern?
Yes.
Really?
That brain pattern stays with us the rest of our life.
To do what? When we eat or drink?
Well, it's in the background, but that pattern is supposed to be replaced with a higher order function.
Right.
A higher order central pattern generator. Think of it as software. So we're born immediately with a very basic light software that, as the brain grows through function and behavior and all that, gets replaced with more and more sophisticated software, if you will. We're always
Yeah, consciousness being at the forefront, that could kind of override everything, right?
Well,
I mean, just when we're talking about breathing, it goes from a subconscious thing that I'm doing to so active. Like I've been thinking about the way I'm breathing this whole time, but otherwise I never think of how I'm breathing.
Yeah, so you bring up a good point. I'm talking right now what's called oral tidal breathing. It's because I have that ability that no other mammal has, that I can actually take pockets of air using my tongue and my lips to make sounds that our brains perceive as language, right? Okay, so that's what allowed us to land a man on the moon and grow our brain. But I'm actually blowing off a lot of CO2. And if I keep on doing this, I'm a little lightheaded right now because of that, some vasoconstriction. And so my adrenaline is actually kicking in to help me with that. So I'm a little bit more animated. So talk to anybody. Now, wake up in the morning, you have your coffee and you start talking, and then you have some carbohydrates and you're feeding those carbs. And pretty soon people are doing that. I mean, you think about little kids, they go to school and they come back and they're talking to mom, and they come back from school and go, Mom, and little Johnny, he was chasing me during recess, and they're talking like this.
That was actually a good impression of how.
Yeah. A lot of us do that. And they're in a little adrenaline state, and they're bouncing off the walls and they're hyperactive, and mom may say, oh, that's just, he's rambunctious, it's his personality traits. Actually physiology.
That's representative of something unhealthy?
Well, it's just a breathing behavior that is not healthy, that can create lots of problems for that kid. And what do? We medicate them because they can't pay attention.
How do you fix little Johnny?
Oh boy, first it's early diagnosis, to get them structurally where they should be, looking at how they're breathing, how they're developing. This is the problem in pediatrics, is that there are these well checks. They're not looking at or asking those questions. They're just, maybe they'll look at the tonsils once they're already enlarged because there's been so much mouth breathing. Now we're stepping in once the fire has already consumed the house. They're not really set to detect the small kitchen fire, right, so to speak, and to nip it at the bud. It's just not what we do in an allopathic healthcare system that's very siloed. But
we're talking about the nursing's effect, but one thing that's really big right now is having the tongue on the roof of the mouth.
Yes.
Should you look at little Johnny and see if he maintains a tongue posture on the roof of the mouth versus hanging on the...
Yes. So I would say a more prescriptive, predictable approach would be to have within the first 5 years of life, and actually sooner rather than later, is to have a good sleep and language pathologist or an occupational therapist that's trained in looking at these benchmarks. So they're very well defined, where, for example, Johnny starts chewing, weans and starts chewing. Initially, it's just a vertical chew, straight up and down. The neurology in the brain hasn't developed enough to have a transverse stroke that might occur at 12 months.
A transverse stroke? What do you mean?
Meaning that they are able to chew more on one side than the other. They just, chewing, as an example.
So when you're really young, you automatically chew on both sides?
Well, typically, let me just say that it's a vertical chew. And then when you start a more advanced chew pattern, because there's more advanced neurology that's developed, is more of a elliptical, think
I chew on the left side of my mouth, I chew on the right side of my mouth.
You're right.
And that's just automatic, where I go
Yes,
evenly?
that's the way we're designed.
Really?
We can get into all that. We do not chew
advanced?
on both sides at the same time.
But when you're young, you do?
When you're young, not necessarily. It's just vertical, that you may be chewing it on both sides at the same time, but also look at the types of food that you're chewing at that time. It's less complex. They don't have the neurology to address structurally more complex food. So that's why an occupational therapist has these benchmarks at where the neurology has developed at 12 months, at 14 months, at 18 months. So there are ways that they look at that, and there are therapies that are implemented to reverse that are science-based, based on studies. So you could see that there's a failure to thrive. Johnny is the weight's not gaining the weight. It takes them a long time to chew, or they're a very messy eater. There are many reasons, largely, oftentimes, to protect the airway so they don't choke, because there's a lack of development in the proper neurology of their chewing function that's integrally related to breathing. You can't separate the two.
Interesting. So the chewing patterns are related to breathing. That's
100%.
Really?
100%. You'll choke. It's no small matter. I mean, choking accidents are the fourth leading cause of death, in accidental death.
Okay.
In the West. Okay, that's not a small number. There's no other mammal that has that problem, and we talked about that last time. Well, that's driven by the software, the neurology. And yet, we're just assuming that Johnny's developing properly when they go to the pediatrician or they go to the dentist, because we're focusing on maybe tooth decay or, other things, dental crowding, other things. We're kind of distracted by signs or symptoms, where it's really the neurology we should be looking at. And you find that that kid doesn't sleep really well. They don't breathe really well. So let me give you an example. We know about, the little toddler that's just learned to walk, and they're running around in their pull-up, right? They're running around, and everyone sees, oh, this got cute. It's kind of like, that toddler walk, because their brain hasn't developed the more sophisticated, smooth gait that they will. And then they fall asleep. And how do they fall asleep?
With their butt in the air.
The little butt up in the air, we call that the tripod position. And, grandma says, oh, look how cute, little bug is up, not realizing that that child is hypoxic and they're in trouble. Their neck is hyperextended. They're falling asleep. The only way they can breathe moment to moment. The other one is...
They're hypoxic? What is that?
Hypoxic meaning they don't have enough oxygen. They're struggling to get that oxygen, opening up the airway. They might have some congested. Their neck is hyperextended, and they're resting in a way that can maintain the airway. Here's the other one.
Why are they struggling to get oxygen? They're...
Because it's a developmental problem. Their palate may be narrow. They might have some swelling in their tonsils because
they didn't get enough exercise from the way they nursed.
That could start. Could start the process. There are many. But how about the other one, where the only way that the baby falls asleep or the toddler falls asleep was they're in the car seat, and we're thinking it's the white noise that's rocking them to sleep and soothing them. Actually, not. Yes, that will help, but their brain is in this fight or flight because they're trying to breathe. And the way they can breathe the best, they can't breathe laying down or on their stomach so well. So they're in the car seat, and they'll move their head, and they'll be able to breathe better eventually than if they're laying down.
Interesting. It kind of forces them into a good breathing posture.
A better breathing posture. Not a good one, a better one.
Okay.
And if you watch those kids, oftentimes they're struggling to breathe. Their chest muscles are really pumping. If you know what to look for, if you take the little jaw and you pull it forward, open the airway, they calm down.
Really?
The breathing becomes quiet. So a child or an adult or a teenager, when they breathe, should breathe like a little mouse, silent, quiet, no turbulence, silent and quiet. If you're sick and you have congestion, that's a different story. And of course you feel it. But by and large, anything that inflames the tissue along the airway that creates turbulence is a problem, and we see it all the time.
So how should adults breathe? Also quietly?
Quiet,
yeah.
No snoring. And
how quiet? So quiet that
you can't hear it.
I myself can't hear my own breathing, or my neighbor can.
You can't hear it.
Really?
You cannot hear it. You
How
put
can
your
you
ear
do
in
that
there,
in-
you could just see the chest breathing. But again, you don't see that very often because they're breathing and they wake up in the morning.
How can I get enough oxygen in daily life if I'm breathing that quietly?
You don't have to worry about getting oxygen. This is the other misnomer. There's plenty of oxygen in the air. The better question is, how can I distribute that oxygen that I take in?
Okay.
And how do you do that? With carbon dioxide. Having enough CO2 in your lungs to have breathing stability. And let me just really go down this little rabbit hole a little bit. I think it's really important if I can.
Yeah, go
Okay,
ahead.
because you asked the question. Okay, just a little physiology. So the hemoglobin that carries 4 molecules of oxygen that we use for work to metabolize, every cell in the body needs that, is released as a function of the gradient of carbon dioxide. So let me give you an example. If I'm doing bicep curls in the gym, okay, there's work going on in my bicep, right? Metabolism. I'm using glucose and I'm creating a lot of CO2. So the CO2 levels in that muscle go up. So the blood coursing through that muscle, that's the hemoglobin that's carrying that oxygen, says, hey, there's a lot of CO2 here. Work must be happening. So the bond between the oxygen and the hemoglobin is loose. So it really easily releases the oxygen to feed those cells to do work. If you're not working and it's just resting, there's not a lot of CO2. And so the oxygen bond to the hemoglobin is a stronger because it's not really needed there. And this is what's called the Bohr effect. It's called, we won't get into it beyond just saying that that's important. So how we breathe, there's this metabolic pathway of how it's supposed to happen optimally to distribute the oxygen we're taking in enough oxygen. So
right, you said we're over breathing earlier.
Well, we're over breathing, or I think it's almost silly, somebody that's walking around with supplemental oxygen to put more oxygen in, that's not really the problem. And yet it's done all the time. They're prescribed supplemental oxygen. It's just they're breathing dysfunctionally. They don't have enough CO2. So I think it's just silly. It's like waking somebody up to give them a sleeping pill. Actually, it's more having to do with breathing properly. Now, if they're not breathing properly, there are some things that can be done, and it can have some benefit. Don't get me wrong, but I think we're oftentimes missing the problem because we just assume that proper breathing is happening, and more often than not, it's not.
Practically, or you said I should be breathing like a mouse, like you shouldn't even be able to hear it.
Yes.
Okay, but practically, what do I do to distribute the oxygen correctly?
Let the brainstem do that with proper breathing, so that the amount of CO2 that's in the bloodstream that courses through the blood-brain barrier tells your brain how to breathe.
But I mean, when I take deep breaths, I can hear it. So I shouldn't be breathing deeply and exhaling deeply?
Okay, so we were talking about sleep, right?
No, I'm not talking about sleep. I'm thinking like I'm taking a test.
Okay, when you're taking a test, optimally, you should not be hearing any breathing, any resistance.
Okay, but how do I achieve?
Breathe normally with a really good airway, tongue on the roof of the mouth, calmly with your diaphragm. So we say there are 5 competences that every human should have to have this optimal. When I say competence, meaning that they do it easily and do it well. The first one is nasal breathing. And therein lies a problem. And by the way, nasal surgery is not the answer most of the time. So breathing through the nose optimally, easily, with low resistance. The second thing is lips together, tongue on the roof of the mouth with what we call a mature swallow, non-collapsing airway during sleep, and diaphragmatic breathing. If you have those functions optimally, everything takes care of itself. Unfortunately,
very interesting.
Any one of those is not working properly, then you're going to end up having a compensation that results in signs and symptoms. And we're just often it's not trained to detect that because we're just assuming you're breathing, you're okay. It's not until you take a blood pressure, or you see some, clenching or grinding, or see some other symptom that you treat that downstream symptom.
So bring me through that again, because I'm thinking very practically, like what can I do to go home and be a better breather? You said I have to be able to breathe through my nose easily. What else?
Again, to summarize, breathe through the nose 90-95% of the time. Okay. Obviously, if you're talking or you're vigorous exercise, different story, right? The body can handle that. Lips together. Okay. So when the lips are together, the tongue is likely on the roof of the mouth. If you separate the lips a little bit, you'll feel the tongue drop. So when the tongue's on the roof of the mouth, it closes off the oral pharynx, forcing nasal breathing or supporting nasal breathing. And then when you swallow, that swallow also allows for proper movement of the bolus of food or the saliva so you don't choke. And then the other is having the pharynx, the airway in the throat, so that it doesn't collapse. Like snoring is when the airway's collapsing. You don't want that.
I can't control that though, can I?
Well, you can. If you're doing that, you have to look at how do you reverse that. Don't just accept that. We know that, especially in children, we know it's super pro-inflammatory during the developmental. It's a real bad risk factor for health. Long term, by the way.
Well, how do I control it?
The snoring, you have to diagnose and look at the structure and the function to see what's like. There's too much swelling in the nose, or the tonsils are too enlarged, or the adenoids, or whatever the case may be. There's too much turbulence.
And the solution is or isn't to get those removed?
It's hopefully catching the problem earlier,
Where you don't have to.
Making sure that there's proper facial growth and development.
Okay.
And then, of course, diaphragmatic breathing. So any of those
breathing from like my stomach, not
from
my
the
chest.
from the diaphragm, not from your stomach necessarily, from the diaphragm, and so that you're connected to it. And that gets into a whole other discussion. But that doesn't necessarily mean a specific rate. Bottom line, it's to maintain optimal end tidal CO2 that you can measure.
So I need to be able to do that subconsciously.
Yes.
Okay, but how do
That happens at the brainstem.
How do I train my subconscious behavior?
So you bring up a really very good point, again, that's missed with people that are talking about breath work and meditation and yoga.
Right.
And so let's go back to the concept that breathing is a behavior. And as my
What do you
friend...
mean by that? Do you mean it's conscious behavior or subconscious
Let me
behavior?
explain, yes. This is what, my good friend, world-renowned physiologist Peter Litchfield would say. Remember that behavior is physiology in action. It's our body behind the scene that is fostering a certain function that we could see as a behavior, but we can control it consciously and subconsciously. So, for example, breathing is a behavior because you breathe differently, whether you're talking, you're in a good mood, bad mood. But the other thing that can happen is there are triggers. There are psychological triggers that can cause disordered breathing. So I'll use this classic example. Let's say you're a 6-year-old little girl, that is in first grade, and you're on the front row because your last name ends in A, right? Sure. And you have a big burly male teacher with a big beard that has a very deep voice that is intimidating because this guy reminds you of your uncle who you're scared of for whatever reason, right? So when you're in that situation where you're sitting there and he's standing right over in front of you, you might have this subconscious trigger to overventilate. You start hyperventilating because that causes what's called dissociation. You start, disconnecting psychologically to the moment. You kind of go off into the dream state, if you will, because you're vasoconstricting, you're over breathing, and you find that serves you for that moment to protect you from psychologically from that situation. So then, little Joni grows up, and now she's in high school and she's in a similar situation, and she's subconsciously not aware that she's now starting to do that dissociation behavior. And then now she's, married and has 3 kids, and anytime she's in a similar stressful response, she goes into this physiologic reflex. There's a trigger there. So the therapy is really looking at what are those triggers, that's just one example, that's causing you to disorder your breathing, that locks you into bad breathing pattern. That same mom may take a yoga class or breath work or even be an instructor to overcome some of these behaviors, not recognizing that there's this underlying trigger that is causing that. So there's a lot of physiology, a lot of therapy, and I'm not talking about psychological therapy, but looking at, okay, so what are those triggers? And so, so I think that's a huge knowledge void when we're talking about breath work and breathing and yoga and proper breathing that's not recognized, is that there are subconscious triggers, and to get to the root cause of that disordered breathing often is addressing that behavior, those triggers. And so there's a whole science-validated approach. You get your master's in learning just how to do that based on understanding physiology, okay, breathing physiology, acid-base balance, and all those types of things. So the point is, I want an appreciation. I want to express that we have to have an appreciation for the behavior piece, the physiology behind it.
Okay. And so how you act, physiology, that manifests in your facial structure, how you look, aesthetics? How?
Okay, so now we're getting into
The next topic.
the next topic. Just to kind of clear this up, can I use an example that, again, my friend Dr. Litchfield talked about in their volumes of research in physiology looking at these types of things. So he talks about this well-studied, well-known study in physiology circles, if you will, where they take these chick embryos, right? They're eggs that are under a heat lamp. And you have a thermocoupler, and you can actually measure the heart rate of the embryo as it's developing in that little egg. And it's connected to the light such that the embryos understand that the higher they raise their heart rate, it makes the heat lamp become warmer. So they can alter their heart rate based on the benefit physiologically they get. They want more heat. That's really well described. These are just embryos.
So
right?
the experiment was set up so that the heat would raise if they... Oh,
and here's the interesting thing. Okay. They reversed it to where when they put a trigger, remember I'm talking about triggers? They reversed this trigger that if they did that, the heart rate actually cooled the lamp down, and they didn't like that. And what was found is very, very quickly the chick embryos learned, it's a learned behavior, to reverse it. So when the stimulus came in, they actually reversed the initial criteria of the heart rate, that they were able to slow their heart rate down to increase the heat. The main point is that this behavior is physiologically founded that served a purpose for the embryos. So there are volumes on physiologic studies looking at how it serves the host. So I want to end with that to say that our breathing serves us to some extent. Some of these triggers will serve us to solve an immediate problem, but what we oftentimes don't understand is the price that's paid for the disordered breathing that are more downstream. Mm-hmm. So what we want to do is get to what nature wants, optimally, what we're designed for, to have wellness versus not being sick. And so we can end this segment, looking at that, and based on our questions that come up, we can take a deeper dive.
Yeah.
But you can really get into the weeds with this science, and this podcast is really not meant to get too deeply into some of the physiology. It's just to have this, a better appreciation that things are not always as simple as you hear on the internet as to how easy it is to change some very important function.
It is really interesting how we can program behavior like that.
Yes.
I think of science very practically. I want to know how it could serve me, right? We learn all this, and I just want to know how I could use it to benefit my life.
Right.
So I want to know how I can program myself to do certain things, kind of how they programmed the chick.
Yeah, right. How about this? You've heard of the Russian scientist Pavlov, right?
Yeah.
Pavlov. So he had a ring, and he was able to measure these dogs salivating based on the ring, right? Okay. They also have studies with mice that they can actually measure release of insulin from the pancreas as a behavior as well. So you can have these triggers to release what otherwise might be considered an autonomic. So that starts getting into diet and metabolic disorders and things like that. But we'll just end it at this, I think with this discussion.
Okay.
But thank you very much.
Yeah. I want to talk about aesthetics really quickly.
Sure.
There's kind of an interesting theory, and it makes sense to me, right? And I think most people are familiar with this theory. It kind of goes as this, right? When we're looking to mate, right, we look for aesthetics, or there's some sense of aesthetics. We could have preferences, but generally there's a common sense of aesthetic that we look for in a face. And why is that? Well, why would we look for aesthetic? It's because it's representative of health.
Yes.
That's correct.
Yes.
But I want to know how breathing ties into the aesthetics, because it would make sense to me, under the assumption that that theory is true, that I would want to mate or reproduce with someone that's healthy because they're breathing healthily.
Right.
You know what I'm saying?
Yes. Okay. So I think the best way to tackle this topic, to start it, is let's just start from the beginning and see if you agree with this.
Okay.
I think most people would say, if you look at a face, high cheekbones, good strong jaw, good straight profile,
Right.
you could start thinking of, let's say, actors, if you're female, Brad Pitt, right? I mean, he's considered attractive. Look at his face. Angelina Jolie, right? You look at her face, look at their profiles. I always joke about, how people, women especially, but men too, will look at just voluptuous, beautiful lips, and you have these fillers to try to make them, to kind of fake it.
Yeah, why are big lips attractive?
Well,
Why is that a thing?
we could talk about that for sure, but
You're telling me, though, that that's representative of someone that's healthy?
well, what happens is that when you have a really good facial bony structure, it supports the soft tissue that
Okay.
defines the lips. When your jaw is not far enough forward, so the further forward that high cheekbone, that, as I used to tell my residents at UCLA, bone sets the tone, but tissue is the issue. Tissue being the soft tissue is what we see, but there's no amount of Restylane that's a substitute for having good bony support. In fact, how we age also is a function of having more bone volume in our face. We're not getting the same bone volume that we used to, and it starts with the upper jaw first, and then allows the lower jaw to come forward. But again, with Angelina Jolie, you look at her profile, that you can measure the nasolabial angle, and you see that large lip where the full lip is expressed and
We have a
supported.
photo of this on your Instagram as well.
Yes, exactly. So those are markers, primitive markers for health. The head is upright, like they're confident because they could breathe, and so there are a number of these markers, if you will. So let's just start with, I think most people would agree that that would be more of a description of a more attractive face type versus, let's say, they're very narrow, very weak jaw. That's when you look on profiles far back, and very thin upper lips, and there's a lot of markers that we actually measure.
So thin lips aren't necessarily attractive because it's an indicator of health or
Deficiency.
the lack of
There's a facial deficiency,
Interesting.
but let's just say, as Don Endel, the grandfather of craniofacial biology, defined decades ago, and a lot of science to look at this, that the airway is the keystone for the face. So when we're born, what is driving that growth to a great extent is the airway to take that next breath. So that ends up turning into a face that either didn't grow right because there are all these risk factors that we just talked about, mouth breathing, there's vertical growth versus forward growth. But what I wanted to start off with what the definition is, if we could agree that maybe that most people would agree that that's a description of a more attractive face versus one that's not so much. Now, it's not to say that individual can't have a great personality and have a big bank account to make them attractive from a psychosocial point of view. Mm-hmm. But if we're looking just at primitive drive, there was a study that was done and is published in the plastic surgery journals, and I can't remember right offhand the journal. Basically, they took a group of women in developing countries that didn't really have exposure to TV and the movies and all that. And what they did, the researchers, is they took a stack of pictures of faces, male actors or male faces that were well known, that were considered attractive at the time. They had square jaws, forward face, high cheekbones, that confident look, right? And then they took a matched contemporary group of faces, pictures of faces that were more contemporary, like more in the last
just normal
decades,
Oh, okay. So,
of actors as well. So they're looking at actors back in the 40s and the 50s, for example, compared to actors that were in the 80s and 90s.
Got it.
Because those faces matched were very different.
Okay.
And interestingly, hands down, the women, 10 for 10, pretty much, all of them, picked the actors and their profiles and the facial types of the older actors from the 40s and the 50s in comparison to the actors that were considered, the sex symbols, if you will.
Really? So they picked even like very attractive actors from
In
the
comparison.
90s, and in comparison.
They were given a choice
Wow.
where they were matched, and hands down. And so now we start looking into, this primitive drive. You don't know what they are, how much money they have, how successful, how charismatic they are, but just from a very primitive drive, what is it that you're looking at? So what we see is those faces were more what we call Paleolithic. They were closer to the way we're supposed to develop as hunters and gatherers, strong jaw.
Even in the 50s and 60s?
Yes,
Why
and it's
is it?
accelerated.
Why is that? Why do they look so different just
Because
that
it's
short time?
radically changed. Even though this has been going on for more than 500 years, there's this inflection that it's accelerating now. There's studies to show, for example, dental crowding globally is now well into the 90s. So it's a problem that's increasing. Type 2 diabetes, just in the last 30, 40 years, the incidence is growing higher and higher. When I was in dental school, they used to call it type 2 diabetes, adult onset diabetes. They don't call that anymore. Why? Because you have
Sure
kids
don't.
now that are 9 and 10 and younger that have type 2 diabetes. It's an acquired condition.
So that's not even just because of the diet. It's more than just that.
No, it's more than just diet. That's just throwing fuel on the fire that's already smoldering. That's a big discussion. It's many things. Things. But I guess the point I'm making is the hardware. So I talk about hardware, software, and the operating system.
Talking about brain function, right?
Well, let me explain. The hardware is our airway. That's manifest in how our faces look, right?
Okay.
And the software are the muscles that stimulate that growth very early on. Those are the muscles, that's the software, and then the operating system is the behavior.
Okay.
So all three, a computer needs hardware, software, and operating system to function optimally. They need to they need to be optimal to be, at function at the highest. Well, it's the same thing with us. We have hardware and software, and the problem in the disease management healthcare system, there's a lack of integration of these concepts. So if you're a surgeon, you're always looking at the hardware. I could fix the hardware. If you're an internist, you're looking just at, or neurologist, you're looking just at the software as if it's not connected to the hardware. And, if you're, allied health professional or physiologist, maybe you're just looking at the behavior part of it. But we have to recognize all three to understand the problem with any given patient, and then kind of step back and say, okay, how are we going to address this as a team that's integrated, where I'm limited in what I could do with the hardware, but I could bring somebody in that can understand that. So now we start getting into interdisciplinary treatment, which is what I teach and practice, is that I can't do this by myself in a complex situation. Yes, a very simple problem we could fix, but these more complex problems that are long-term, that are related to chronic disease, really require more of a team approach where the pill is not the answer.
Then what is the answer? Lifestyle?
Well, first is proper assessment and diagnosis. Like, what's really going on with this individual? Yes, maybe you have a genetic predilection or a genetic condition that sets the tone, but for the most part, if you're looking at a perfectly healthy individual that can be chronically sick, let's say somebody that has sleep apnea that was healthy their whole lives, and you start looking back, the problem didn't just start it's something that took decades to manifest to where now it's being recognized. It's kind of like I always joke about how, cancer, we have a healthcare system that treats the cancer now once it's metastatic, right? But how about when it was stage 1 or carcinoma in situ? We really need to be looking at the problem earlier on. It's also less expensive for the healthcare system if we're catching this problem earlier on than waiting till it's, a chronic problem.
So how come the actors in the 50s and 60s were so much more preferred than, or
Now,
I understand
they were
why
more attractive to that
Right.
population of females that were just looking at just, facial structure.
Right. I mean, why have our faces changed so much? Specifically, is it lifestyle, and what in the lifestyle?
Environmental factors that we have changed radically, starting from going from the hunter-gatherer Paleolithic period that ended or started ending around 10 to 12,000 years ago in what became or is defined as the agricultural revolution. That's when we started civilization, right, in the Fertile Crescent. And then we started controlling our food, and then we domesticating animals slowly over time. And then about 500 years ago was the Industrial Revolution that started changing the role of females in the workforce, and the advent of wet nurses, and so there are many, many factors, and it's its own discussion, to be honest. But there are these changes in the epigenetic or environmental factors that have radically changed how we look, how we function, how we sit, how we sleep. Those are all factors. Back in the day, we didn't have chairs. Now you hear about how these modern chairs that really address the way we're supposed to sit, even commodes, right? You know about that, the squatty potty, how our intestines are supposed to really function.
Right.
We've radically changed with a lot of conveniences, but there are these downstream consequences that are so nuanced that we've kind of really just now are starting to understand that maybe there's some bigger things that are going on here that we should look into. And that's what we're talking about in this podcast.
Yeah. And I guess if I want to know all the specific things in our lifestyle that even, of course, big changes from now in the time in the Fertile Crescent, but then even from 50s and 60s to 90s,
yes,
that I want to get into. It sounds like there's enough, though, that's like a topic for its own episode.
Agree.
Okay.
Let's make that maybe our next episode where we get into all these environmental risk factors. I'll just throw out an example. We've got 2 examples.
Okay.
Real quick. That modern medicine has, for instance, the C-section, where it was okay for an emergency situation because you had to breech delivery, right, to save the mom's and the baby's life. It got to the point back in the 80s and the 90s where now they were being scheduled. Oh, I've got a vacation. Let's take the baby at 38 weeks, versus the 40th week or whatever, where that now a lot of hospitals have reversed that. So sometimes there are unintended consequences. It seems like it makes sense. What's the big deal? Let's go ahead now.
What is the big deal? What's the downside in the C-section?
We're going to talk about that the next time. Or the other is nursing, using bottles.
Right.
Or we talked about it last time, the types of foods and how we've controlled our foods to the point where now we've changed how we even eat. That's created intestinal dysbiosis and food allergies and sensitivities and elimination diets and things like that. Leaky gut, those are all diseases that we didn't have that problem. Peanut allergies. There isn't a school now in the United States where you can't go into a classroom in elementary school where there's a caution that if someone has a peanut in that room, you might have to call 911. That never happened before.
Really, the allergies weren't?
They're anaphylactic in nature. And so those are things that are recent.
Were allergies
We
not
never had that
really?
All these. So there are lots of examples, and so the questions are, they're complex. So it's not one thing.
Is that a Darwinism thing? The reason we didn't have, meaning that.
No, I don't know that it's Darwin. It's an environmental thing.
Really? Okay.
It's what's happened with our environment. We could start talking about grains, how we've radically changed because we've engineered our food differently because it's more efficient to address world hunger. I mean, look, Whole Foods has made its profits and its name based on, selling organic foods and non-GMO. So those are just some examples. I'm not saying it's a right or wrong, okay? I'm saying that we're recognizing that there are environmental risk factors from controlling our food supply, not just what's in it, but how the form that it's in, that we take it in, that have contributed to our chronic disease.
Okay.
So let's talk about that maybe in the next episode.
Okay. Yeah. We'll get back to the aesthetics. Interestingly, one part of aesthetics that a lot of people look at is symmetry.
Yes.
Why is symmetry considered aesthetic?
Well, I will argue that it's not necessarily about symmetry as much as it is about harmony. Let me explain the two.
Meaning proportions.
Yes.
Okay.
Exactly. So, the only thing that's symmetrical are man-made things, buildings, structures, that we make symmetrical because we say that's the way it should look. But there's nothing in nature that's really symmetrical. I mean, you look at a beautiful oak tree out in the middle of an empty field.
Sure, no, I understand what you're saying.
You could take a chimera where they've done studies where you take that tree that's not symmetrical, but it's just beautiful, and you take half of it and duplicate it and make it the other half, and you do both halves.
Right, but you want one side of your face to look the same.
To harmonize, yes, to harmonize, right? You want there to be certain proportions. There's a whole science using finite element analysis that I think also to some extent is flawed because it's based on a construct. But nonetheless,
you're talking about the golden ratio kind of
golden
thing.
Golden ratio that goes back to Pericles, goes back to the Greeks. Right, exactly. Looking at buildings, looking at faces, looking at nature. Again, they were talking more not so much about symmetry, but harmony.
Okay.
So when we're looking at facial attractiveness and you look at something that's very, very attractive, usually someone that's also much healthier. And by the way, that can also be a function of other senses like our smell subconsciously, pheromones, or if, let's say, you're type 2 diabetic and you're, at a bar and some attractive female comes up to you that maybe facially, looks like, you're attractive, or, you whatever that case may be, not necessarily even looking at the face, but she subconsciously could smell ketone bodies because you're type 2 diabetic. That immediately is like not good. There's some conscious I'm not so attractive. Why? Because, if you're, eventually going to have kids, the kids may be at higher risk. The progeny may be more diseased. So there are all kinds of studies looking at that. Smells, sight.
Right. What you're saying is that different, you portray certain things through manifestations like you were talking about the posture earlier, which I thought was interesting.
Yeah.
I think posture is seen as attractive because it portrays confidence, but you're saying it could be, another theory is that it could be more about how you breathe. Like this is putting you in a good position for your airway.
Yes.
And that might be why it's seen as attractive.
Right. So let's just say that we have an optimal facial growth on an individual, right? Let's just say that. If you look at that individual's posture, likely their head will be right over the shoulder because of the feedback loop from the motor cortex that's basically governing where this 8 to 9 pound bowling ball, if you will, of the brain should be over the shoulders. It's most efficiently held over where the earlobes are about mid-shoulder. And there's a feedback loop that allows that also portends to health of C1 and C2, the cervical spine, with a natural lordosis. That's the way it's supposed to be. That would be like what mom would say, that's a good posture. But if you don't have a facial development profile because your airway is small, because you had adenoid facies growth, like it's too long, you're going to have a tendency to have a head tilt.
Right.
Because when you have that head in that optimal approach, optimal position, it's going to compress front to back the pharynx, the airway. There's going to be more turbulence, and there's this feedback loop that overtakes what's more important, taking that next breath.
Right.
So you tend to slouch. So
just to get as much air as you can.
right,
At this moment.
you're doing it subconsciously. It's called the head tilt. So these are some of the things that we know diagnostically. And so then now you see that little old lady who's in her 90s that walks into the room, or that little old man with their head that's, comes into the room 10 minutes before their body does, right? They're breathing. But that problem started way, way early. And those are some things that we want to address. The dental crowding and the temporomandibular joint health are really related all to those structures. But again, going back to healthcare, that's not the way we treat our patients, right? You have someone, the chiropractor that treats the cervical spine. You've got maybe the dentist or orthodontist that treats the
very silent approaches.
It's very silent. No one's putting it together, and everyone has their theory. Oh, I've noticed this. Well, let's kind of step back and take a really good science-based, integrated approach, and you start seeing how intuitively logical it is when you understand how the body's supposed to work, and therefore how it's supposed to be treated, where you recognize these global problems beyond just a siloed point of view.
Sounds like if we could get the breathing right and the airway right, we would not only look more attractive, everyone, but also function better. We'd end up in the ER, we'd end up in the hospital less. Take a lot of pressure off the healthcare system.
Oh, no question about it. And of course, it's not just as simple as that, but I'd like to summarize it this way, that from first latch to last dispatch, or another way of saying it, from the first breath that you take to the last breath that you take, the most important function physiologically, and I don't think anyone can argue with this, is taking the next breath. Because that oxygen is what feeds every cell in our body through growth and development and beyond, right?
And that's why we mouth breathe and give the head tilts, because we just want to get to the next breath.
Exactly, right. That's Latham and Scott back in the 1970s called that, had a term for it, and they wrote about that. And it's, no matter what, the body is going to do what it takes to survive that next moment. Not worried about whether it's living a year from now. You just have to worry about getting your genes to that next generation, then you die, right? So
right, interesting. Okay.
Yeah.
That's why we don't really care what's or subconsciously we're going to go for what just gets us there, next step. Doesn't really matter what's optimal if we're just trying to survive. Okay. That makes sense.
Right.
Earlier we were talking about, you said it's not as simple as I was saying. We're kind of course, for healthcare, a lot of different things can put you in the hospital. It's not just that.
Yes.
But I thought it was interesting, you were talking about type 2 diabetes, and that breathing has a lot to do with that. That's or not just type 2 diabetes, but you were saying hypertension.
Yes.
That's very interesting to me. I'm...
Can we let's take a pause right now?
Okay.
Because that's a really good topic to talk about.
Yeah, we'll pick up in the next episode.
Yeah, let's definitely do that, and
we'll go into environmental risk factors, why we look so different 50 years ago, 10 years ago, 20 years ago, 30 years ago. We can go through all that.
Beautiful.
Awesome.
We hope that the format of our casual conversation provides a construct for how to think about the problem rather than just saying how it is.
In order to stimulate a continuing conversation and give room to ask your own questions or comments, please follow us on Facebook at Mark A. Cruz DDS or on Twitter at Mark Cruz DDS.